mark that starts to happen.
Okay. Yeah. It's well, I've had my booster and I was neither up nor down. So there we go. Okay, so sometimes these questions come in, we don't get enough detail. I'm flipping from what my list to this one because I'm at this person who's asked this following question I'm going to read out. There's not a huge amount of information, but this question is a concern, which Andrew will understand when I read it. So this person, if you're watching, I know you put this question in on Facebook, then perhaps you could send more information and we'll tell you what would be helpful. So you say, my gastro consultant has now stated he doesn't think I have PBC as my AMA titer is 180. My alkaline phosphatide only marginally raised and my AST is raised. What are your thoughts and should I be asking for a review? Now, Andrew, we do hear from time to time people are told wrongly that, you know, it's been a mistake in the diagnosis. Not always, but a lot of the time. This is a concern. What would you say to this person?
I think, look, you know, in terms of how we make a diagnosis of PBC, if you have an elevated alkaline phosphatase and you have any measurable AMA, you are considered to have PBC. Now, I think the titers of AMA, so that's the how abnormal it is. So sometimes it comes back, the lowest is usually 1 in 40, 1 in 80, depending on how accurate your labs can be. Sometimes it goes up to 1 in 640 or even 1280. But if it's elevated with an elevated alkaline phosphatase, we would regard anybody really as having PBC. The broader question is, you know, could somebody have what we call an overlap syndrome, where it looks a little bit more like autoimmune hepatitis? That's sometimes a possibility, but I would say that if her AMA rather is at that sort of 1 in 160 is normally the sort of the divisions it comes in and the results, that would be compatible with PBC still. We know a reasonable proportion of people with PBC will also have an elevation in the ALT or the AST enzymes as well as the alkaline phosphatase. So it doesn't have to be just alkaline phosphatase that's elevated. So I would certainly, based on that relatively limited information, suggest that I would still manage that as PBC, and I would still treat that as PBC. We sometimes see that the AMA levels fluctuate down to almost undetectable sometimes, but certainly if it's persistently elevated and 1 in 160, 1 in 240, those would be at levels that would be, you know, still be considered clinically significant, and with a raised alk phos, that would be compatible with PBC still.
And so what I want to say to this person as well, it could well be that you've been treated for PBC, given urso, and that your liver function has come down. Now, we've heard of this before, and our doctor will say, oh, well, you don't need to take urso, you've not got PBC. This is not the case. So this person, you're more than welcome to come back and give me information or give us information. But your thoughts, your question is, should I be asking for a review? Yes, is what we're, yeah. Okay, lovely, thanks for that. Okay, so what information can you tell me about, great question this, post-transplanted recurring PBC? So what are the chances?
Well, it's said to occur in about between 1 in 5 and 1 in 4 people, okay, which sounds quite a high rate, but don't be too alarmed, okay? Because we know in the vast majority of people who end up having a transplant of PBC, it takes a long time for PBC to lead to the damage that requires a transplant in the first place. But also there's potentially something different about the way the immune system behaves when you've had a transplant and you're on immunosuppressant drugs. So actually, although around 1 in 4, 1 in 5 people who've had a transplant of PBC will develop some recurrent PBC within the new liver, it's actually pretty rare for it to lead to severe consequences of cirrhosis, end-stage liver disease, and requiring retransplantation. It is actually very rare that happens. So in general, you know, transplantation is an excellent treatment for people with PBC and cirrhosis and complications, and the likelihood of actually getting clinically meaningful PBC back is actually very small.
Okay, excellent. Now, for those out there, can I just remind you, I'm not a doctor and I'm not a nurse. I'm an accountant, and my pronunciation of big long words is not very good. And no laughing out of you, please, Dr. Yeoman. So, does taking mycophenolate mycophenolate
Yes, well done.
have any effect on PBC? Taking it for another autoimmune disease, having terrible bowel and tummy problems, has had this before with PBC, but much worse now.
Yeah, it's a really interesting question, and I think coming back to what I said about how PBC behaves after a transplant, although if you in the days when we used to do protocol biopsies after a transplant, which is basically a biopsy every year, we don't do that anymore, thankfully. But in the days when we used to do that, as I said, this is where we found PBC occurring in a proportion of people who'd had a transplant for PBC. But as I say, immunosuppression might modulate or might alter the behavior of PBC at a very early stage. Now, that's never been convincingly proven in people who've had a transplant for it. But there's been a lot of interest in the past and even today in terms of how you might prevent PBC from developing and becoming established. Because when most people are diagnosed with PBC, a lot of if you do a biopsy, you find a lot of fixed damage of the bile ducts. But at some stage, there would be a process or a period where the bile ducts were inflamed but not scarred and damaged. And so people have tried mycophenolate mofetil, which is a drug a bit like azathioprine. It's an immune suppressant drug, to try and see if that prevents the progression of PBC and improves the amount of inflammation and damage. And unfortunately, the trials weren't particularly conclusive. Now, they weren't very long-standing trials. In other words, they didn't follow people up for very many years, which is what we've done with URSO. It took us a long time actually to convincingly prove that URSO makes a real meaningful difference in PBC. It really took a long time for that to be evident. You remember that, Collette? And
I do. I'm that old, yeah.
when I started out in hepatology, the jury was still out on URSO as whether it altered the natural history of PBC. We're now very clear that it does because we've accrued the data over long enough. So, so the evidence at the moment is that mycophenolate doesn't convincingly improve the parameters in relation to PBC, but there are some patients on these drugs for other indications where we've seen the liver tests improve. And we've certainly, coming back to what I mentioned after the first question in terms of people with PBC who have other raised liver enzymes, so that's the ALT or the AST, the signs of liver inflammation, then potentially it always seems attractive to try and switch off that inflammation through those immunosuppressive drugs. So we don't have convincing evidence, but I have sort of anecdotally seen people on mycophenolate, and I have used mycophenolate in the odd person with PBC in the past and seen some improvements in liver tests, but we don't have convincingly good data to show that that's the right strategy longer term. But if you require it for another condition related to your joints, for example, that's the commonest reason it might be used, then there may be an improvement in your liver tests with that. But as I say, the jury's out at the moment.
I would also get to this lady person was talking about the side effects. Do you know one of the most underrated services in this country are chemists? Chemists become highly qualified. They've been to university for, I think it's 3-4 years, and they know almost every interaction. It would be, I mean, do tell your consultant what you've been suffering, but have a wee word with a chemist. Would you say, Andrew?
Yeah, I would. So thanks for reminding me of that, because actually you've triggered my mind into something that was raised in the question. So the commonest side effect of mycophenolate is diarrhea. Okay, and actually a dose reduction can sometimes make a big difference in terms of the amount of diarrhea that people get. So it can cause upper GI upset, so upper gut upset as well. But diarrhea is certainly very common on mycophenolate. So if that's a particular problem you're experiencing, then have a chat with the team that have prescribed that drug for you, or a pharmacist, and they'll be able to give you some more advice about potential alternatives if that could be the trigger of your symptoms. Are you still there? Hello?
Hello everyone, it looks like we're maybe having a little bit of a technical issue tonight, so if you please bear with us and we'll try and resolve the problem.
Okay.
Back with us.
I had a big notice up saying you've been disconnected. Give us a moment to sort the problem.
Okay, I was just letting people know we had a couple of tech issues, so
Yeah.
try and get back on. Okay, so continue to enjoy, very interesting so far.
Thanks, Alan. So Carol, just go back to there we go. Yeah, that seemed to be an internet thing, Andrew.
Yeah. I wasn't sure if it was me froze or somebody
Yeah,
else.
no, I got booted, but they brought me back in. They obviously thought I was a kindly person.
They wouldn't dare, Collette, would they? They wouldn't.
No,
dare.
absolutely. So I think we're unfrozen now. Just about the gastroscopy, what are they looking for with the gastroscopy? Oh, they have a good look at a number of things. But remember what I said about, I was saying, Andrew, about sedation. There's a choice of throat spray or sedation. If they're going to be sedated, don't take the car. So what they're looking for, without too much detail on that one, because some people are quite squeamish, me included.
So the first thing to say is not everybody with PBC needs to have an endoscopy routinely. There's probably two scenarios in which you would probably request an endoscopy in somebody with PBC. The first would be for symptoms, whether that's pain, acid reflux, or difficulty swallowing. That would be probably completely independent to the fact that you've got PBC. But the other reason why you might request a gastroscopy in somebody with PBC is to look for something called varices. And we would tend to do that, not always, but we tend to do that when you've got evidence that you might have scarring of the liver to the degree of what we call cirrhosis. And that might have been determined on a liver biopsy. It might be suggested on an ultrasound scan, or a fibre scan might have been done, which might suggest that you could be at risk of that problem. And therefore, the medical team want to look for something called varices. So varices are distended veins at the bottom of your esophagus, of the food pipe, that occur as a result of partly a result of the back pressure generated by a scarred liver. So if the gastroscopy is in relation to your PBC, that's what they'll be looking for. Be looking for these distended blood vessels, which could cause problems in the future if they are present and they're large.
Just to say that I was diagnosed in 1994, 100 years ago, and the policy at the hospital where I go to is every patient gets an endoscopy. I think it's every 4 or 5 years. I can't remember. I've had loads. So what you're talking about, so I think maybe it's regionally variation. Would that?
I mean, I think back in the day, I think we used to do an endoscopy in everybody. Okay, and that's because back in the day it was called primary biliary cirrhosis. Whereas we know that only about 50% of people develop cirrhosis from PBC. But also there was always the historical teaching. I remember James Newberger teaching me this back in the day, that there's a proportion of people with PBC who can develop varices without actually having cirrhosis, although that is actually pretty rare. It's a lot more rare than we used to think it was. So
so it's precautionary, really, then.
Yeah. So it's a precautionary thing to look for distended veins at the bottom of your food pipe. And remember, your medical team will have access to information that Collette and I don't have access to. So we're not sort of demanding that recommendation from them. I'm sure they'll have very good reasons for it. And the main thing they are looking for, if it's in relation to your PBC, is these varices, which if you've got them, sometimes need little rubber bands put on them, or sometimes they give you beta blockers to reduce the pressure within them if they're there.
Yeah.
If they're not there, obviously, then they will just continue to monitor things depending on the stage of your underlying liver disease.
Yeah, so it's treatable, but it's
Absolutely.
it's precautionary, and it's probably a wise thing to do. Now, Hillary on the screen there, just a question about weight gain with Urso. She's 1250 daily. Do you know, when I first went on it, they denied the weight gain, but now they've admitted it. On PPI medication, I don't know what PPI meds are. Oh, you're on Meprazole, right? Okay, the last month I've developed fluid retention in your legs, abdomen, and weight gain. Can they be related? Started these medications in June.
Okay, so you've been on the Urso for a while, I presume. I mean, I think so. So yeah, so Urso, sometimes I have seen people gain weight on Urso. The first thing to say about if you gain weight on Urso in a general sense, sure that you remain on the right dose of Urso, because Urso is a weight-based drug, and if you're going to get an optimal response, it's best that you're on a certain weight-based dosing of the drug. So if you've gained weight for whatever reason, you might need a higher dose of Urso. So that was worthwhile discussing with your doctor or specialist nurse. A Meprazole, which is a PPI, it stands for proton pump inhibitor. It's an acid-reducing treatment that shouldn't cause fluid retention. So I think if you started developing fluid retention in your legs and your belly with weight gain, then you need to get in touch with your medical team as soon as you possibly can. Okay, that does need attention, and they need to make certain that that's not related to your underlying PBC. There's other reasons for it as well, of course, but we should take the assumption that that is related to that until the team can exclude that possibility. And you're going to need an urgent review, really, to get that checked over. You may well need medication to control that, and you'll almost certainly need an up-to-date scan to check on the condition of your liver and to see if there's a lot of fluid in the belly and have that treated. So
it's really important to say at this point as well, and I'm sure you'll agree with this, Andrew, and this is for if you have PBC on its own or you have other conditions as well. Any major change like that, any change that concerns you, always report it in, check it in. Phone in hospitals, I don't know, it's a good idea. I would rather just email your consultant, give them an idea what's going on. Don't write War and Peace, just a sharp, short email. This is a change, and I'm very concerned about it. Could you guide me through it? Could you give me some steps to take, or would you like to see me? So always report it in, I think. Yeah,
absolutely. One other thing, in general bit of good advice, if you start to develop some leg swelling, particularly if this could in any way be related to a liver problem, is to try and look at your salt intake and try and reduce that down as much as possible. That won't necessarily get rid of it all, but it might help minimize it a little bit whilst you're getting that expert opinion and assessment from your medical team.
Yeah. The other thing that's important to say now, this weight, now people have gained weight with COVID. We gain weight as we get older. Nobody's throwing stones, because I did the same. But do register your weight and check the chart, your Urso chart, and make the adjustments and let your GP and your consultant know that you've done it. And it's okay to do that. We've just, I think we've got 10,000 beautifully laminated weight charts in metric and imperial, but we are going back to imperial, which suits me, my age. So we're sending you one out. You're all going to have one. You can stick on the fridge or do. So keep an eye on that. Now, just, and interestingly enough, because I've lost 3 stones away, I've dropped a tablet. So it works both ways. So keep an eye on it. Don't always rely on people around you. Take ownership of it, okay? And good luck to your lady there who's to send that in. And a really good question here I've got in front of me. Is it safe to have a different booster than the one you've had originally?
Yeah, that's a really good question. And I think we get asked that a lot. And actually at the moment, I think most people will probably be given the Pfizer vaccine, okay? Some will be offered the Moderna. We're not using as much of the AstraZeneca now as before. So if you've had one of those 2 in the first place, you'll almost certainly have the same one. But they're making it very clear that you may well be offered a different vaccine to the original 2 doses that you've received. That is fine. Okay. Yeah. In fact, I've seen some data which suggests that it might even give you an additional boost, because the AstraZeneca vaccine and the Pfizer and Moderna works in slightly different ways. So you might get a different boost to the degree of antibodies you get from having a mixed type of vaccine. So it's perfectly safe to do that.
And living proof. So my first two were Pfizer, and I just had the Moderna. And interestingly, Andrew, if you've had your booster, it's only a small amount in the booster, isn't it? It's just a tiny little bit in the syringe. I was looking at my husband having it done, and it's about 0.25 mils or something. It's very, very small dose. Yeah. Well, it was a really good question. That
it is a great question.
Yeah. I have a transplant. I've had a transplant due to PBC. I'm about to be put on azathioprine to protect my kidneys. Should I be worried? I'm 3 years post-transplant.
No, I mean, I think the transplant teams know what they're doing. I mean, this is what they do for a living. They do this all the time, and I think certain the immunosuppressant drugs, particularly sort of Prograf or tacrolimus, can certainly cause a bit of kidney dysfunction, and sometimes they will reduce the dose of that to try and preserve some of that kidney function. Sometimes they'll stop it altogether, and they will utilize other medications. It's pretty unusual for them to use azathioprine alone as a treatment, but sometimes they do need to make these adjustments to look after the rest of your body as well, because we know that some of the immunosuppressant drugs we use after a transplant can have some negative effects on kidney function, and it's really important for your long-term health that those things are looked after as well. So they will be monitoring your liver closely whenever a change is made. So as long as the measurements and the monitoring is in place, that's an entirely appropriate thing for them to do, and they've done it for good reason by the sounds.
Okay, brilliant. I've got a cracker of a question now. I love doing this. I used to be really nervous about it. I'm not. I love it now. If my consultants who are in Carmarthenshire area are still unsure, could you make contact with a PBC specialist in Wales? His name is Dr. Andrew Yeoman, and this is the young man to whom we refer. Now, Andrew, I'm telling you, yes, just do it. He refuses no one. He's not allowed to.
Yeah, no, look, I think, all joking aside, thank you. But we do work collaboratively across the NHS generally, but certainly I can only speak for my own experience within Wales. We've developed some informal networks. I mean, in fact, in relation to when obeticholic acid became available, we set up a virtual MDT, which basically is there to provide advice and guidance to make sure that there's equitable access to OCA across the whole of Wales for everybody who needs it. And also for some consultants who perhaps don't see as much PBC as others, for us to get a bit of groupthink, get our heads together, because there'll always be individuals whose particular clinical situation will fall outside the bounds of the normal and requires a bit more thought. And so we have this virtual group that is facilitated, it's all done confidentially, of course, to be able to try and make the right decisions for patients. And so we do work in a coordinated and in a networked way. And I've always had an interest in autoimmune liver disease, so I see probably more of it than many other people. And that's the difference, really. It's not that I'm a better doctor than anybody else in any other part of the world. I just spend probably more of my time looking after people with PBC and autoimmune liver disease than other people. So yes, we're always happy to work together with colleagues. We use the virtual MDT, and we do talk to one another, and we do cross-refer, and that's not a problem.
Well, that's excellent. So which hospital do you work from, Andrew? It slipped from my mind.
Yeah, so I'm based in the southeast. So I'm based in Gwent, which is the old Unity Authority of Gwent, which is in the southeast of Wales. So I used to be based at the Royal Gwent Hospital, but we've now moved up to a new hospital in a place called Cwmbran. So you don't need to know the minutiae. I'm down the southeast of the country, near Newport.
Right. Yeah. Okay. So it's Dr. David Andrew Yeoman, sorry, and David Jones et al. They do this in these liver units. People who do, like you, see a lot of PBC. These doctors are very happy to share the knowledge and help people along. So, and you couldn't get a better chap than our Andrew, I can tell you. Now, this is another good question, and the answer is, I had mine on the same. What's the opinion on having the flu and booster vaccines at the same time? That's quite a lot of people are rolling this out. I was given the choice. I thought, oh, to hell, just yes, and I did it. But I don't know, what's the opinion on having it? Is there a...
Yeah, look, I think it's I think I'd probably be guided by, first of all, flu vaccination is important. If you're in at-risk group, please have your flu vaccination. Whether you decide to have it at the same time is really down to a personal choice. But think about how you were after your last COVID vaccine, for example. If you had a rotten time, it might be better to split it. Whereas if you were fine before, then, you know, it doesn't always follow, but you're probably a bit more likely to just be fine the next time round as well. You know, I had my flu and my booster on the same day. I even went for the same arm, Collette, because that's how tough I am.
Oh, wow.
But no, actually, all jokes aside, the reason I chose to do that, I thought, well, if I get a really sore arm in both arms, I won't be able to sleep at all, will I? So at least if I got one really sore arm, at least I can lie on the other side. So you know, it does come down to personal choice. There's no particular medical reason why you can't have them both on the same day. It just comes down to how you felt probably after your previous vaccine. And if you've had the flu vaccine before, did it wipe you out for a couple of days? Did you have a really sore arm? And if you have, maybe just split them up a little bit so that you're less likely to flatten yourself. Some people do get a nasty reaction in terms of get the myalgia and the chills. That's the vaccine working, okay? Doesn't mean to say it doesn't work if you don't get those reactions, but it's okay to have those reactions, and they are reasonably common. So if you've had a previous adverse reaction or felt a bit lousy with either the flu or the COVID vaccine, then you may prefer to just defer the flu vaccine for a little bit later.
Yeah. Okay. It's a good question again, though, and
it is.
It's and I've been having the flu injection for 20 years now, and I've been very lucky. I've never had a reaction, but they do say that if you've got an reaction, you absolutely know it's working. So our next question: I've just started taking folic acid. And some reports I have read say no if you have liver disease. As I have PBC, what should I do?
Yeah, it's fine. I mean, folic acid is essential for healthy blood cells. So, you know, some people, if you are deficient in folic acid, then it's appropriate. It's not really toxic. It doesn't accumulate in liver disease. I wouldn't be concerned about that whatsoever. The one thing I would say about folic acid is that it can sometimes be low when you measure it once if you've you know skipped, if you had a long fasting period, and so sometimes it's worth having it rechecked. Just to make certain that it's still low, because you know the folic acid levels do fluctuate quite a bit during the day, and so if you check it after you've missed your breakfast and you've not eaten for sort of 16 hours, it can be a little bit on the low side, and it doesn't mean to say that you're really deficient in folic acid. It just means that there's been a long period between your meals. So so it's often worth getting it rechecked, but certainly I'm not concerned. We use folic acid whenever we need to use it in people with really quite advanced liver disease. And it's important, if it is very low, that it is replaced, because it helps normal red cell functioning. So it is important.
I think sometimes, I mean, even URSO, it says don't take if you have liver disease. I think sometimes a bit of a blanket statement made on drugs. And it's really about legal belt and braces, isn't it? It's companies trying to protect themselves.
Yes, it is.
Now, the question we had earlier, if you remember, at the very beginning, we didn't feel that we had all the information about her PBC and her numbers, and did she have it? The consultant was suggesting she did. So she's come back and she said her phosphatase was at 205 in February 2021.
Yep.
And it's now at 122 due to URSO.
Great. It's working.
Which is great. And she says, but just how quickly can this change? Well, of course, everybody's different, isn't they? But this is good, but this is not indicative that she doesn't have PBC.
No, what that lady's got is treated PBC, and what that lady has is a good response to URSO, which is fantastic. That's what we like to see. Now, sort of, 70-80% of people will have a good response to URSO, and that means you're in that category. But it would not be advisable to stop it. What we always like to see, we like to see the alkaline phosphatase level less than about 200. Okay. And the more normal, the better. And the more normal it is, the less likely it is that your PBC will progress in the future. So it's absolutely important that you continue on with the URSO. It's, as you say, that almost rubber stamps the diagnosis, because you've had the raised alkaline and it's responded. So
that's a great point. But if this person is unsure further, I'm happy to speak to you direct. You'll get my number from the office, and I'll give it to you, and I'm happy to have a chat with you. There's another good question, and we've got a bright lot in this week. When with itching, which I have none of. How quickly can this start and where on the body?
Well, so itching and PBC, where to start, isn't it?
Where do I begin?
I'm not going to sing for you. The thing with itching is that, apart from the fact we don't truly know exactly why it happens, it doesn't happen in everybody with PBC. It doesn't relate to the severity of your PBC in terms of how bad your liver disease is.
Yes.
And even when you have it, and you can have it quite bad, it can fluctuate really quite wildly. And so I've seen people with really quite, intractable itching, and we've really struggled with medication to control it. And then for whatever reason, it just goes away. It's a really, really odd phenomenon. So it can come on, and, some people have itching, and that's how they get diagnosed with PBC. They have itching, go to their doctor, they have a set of tests, the liver tests are abnormal, and we go down that path of investigation, and you find that yes, PBC is there, and it all then sort of makes sense. But you can have PBC for years sometimes and be free of itching, and then it can come on. If you didn't have it at the time of diagnosis, always think of secondary causes of pruritus, which is the medical term for itching. So think about things like, your washing powders, your detergents, anything else changing your environment, your clothing. Think about those sorts of things. Are you exposed to anything else environmentally in the workplace which could have caused skin irritation? Because there are non-liver related causes of itching. But in essence, itching and PBC, it's difficult, it's variable, it can come and go, so it can come on at any time, and it can wax and wane. So it's a really funny one. So anything goes when it comes to itching and PBC.
You make a good point about it not being indicative of severe disease. Now, you and I will both know people who sometimes the itch can be so bad it has a marked horrendous people have horrendous quality of life because of it.
Correct.
And in very severe cases, they will look at you for transplant. Now, I know a few, obviously, in the job I'm in, but one in particular, she was a young woman, she was in her 30s, and her life, she had no life, it was it. And they did transplant her. And here's the belter. The liver they took out, there was next to nothing wrong with it.
Correct.
So it's a great mystery. But I would go on to say to this person that it could all be your liver itch. But listen, just while you're here, we have a survey online at the moment. We're keen to hear from everybody. If you don't itch, if you do itch and it's treated successfully, if it's not treated very successfully, or it's making your life miserable, we want you to fill in that survey. We need the researchers to have as much information as possible, and it's only us that can do that. So please go onto our website. I don't ask very much of you, but please do our questionnaire, because these people need to know. Is that fair, Andrew?
No, I completely endorse that, Collette. I mean, this is the way we move forward, is collectively. And I think, one of the great things with working with the foundation over the last few years has been that co-production of research, clinicians and the foundation working with patients to try and better understand how PBC behaves, exactly how many people get it. And then we can start to try and eventually design better studies to work out how to treat it better, because we still need better treatments for it. There's no doubt about that.
Yeah, and it's really needed. It's terrible. It really is. Another wee belter here. What's the maximum amount of alcohol you can have when you go out, and if it's only now and again?
So I mean, I think if you look at what government guidelines are around alcohol consumption, it's recommended that everybody should drink less than 14 units of alcohol per week, whether you're a male or a female. Now that's whether you have in people who don't have a liver condition. If you have a liver condition, then you need to be a little bit more circumspect again, because obviously alcohol and PBC could accelerate the damage that can occur in the liver from either the PBC or alcohol on its own. So they become what we call synergistic. They have a multiplicative effect on the risk of liver damage progressing. So certainly if you have another liver condition, whether that's PBC or hepatitis C, then really you need to be very cautious with your alcohol intake to avoid those two conditions then sort of accelerating the damage within the liver.
Yeah. Now, Andrew, I'm quite concerned about the person who sent in the next question. This person says, I'm in pain all the time in my bones and my joints. Life is so hard right now. I want to give up. Fatigue is horrible as well. My skin, when touched, feels like I've been punched hard. Is this PBC related? Now, I'm just going to say this, and I'm going to give this to Andrew. I would like this person to call the office and get my private mobile number, and let's have a chat, or a number of chats, because we've all felt like that from time to time. But we're walking along beside you, and let's talk it through. Andrew will give you some good medical pointers here. But please, all that aside, please contact the office. I would like us to communicate.
That's great, Collette. I'm sure that'll be very welcome. I think from a medical point of view, could this be PBC related? Some of it could be, yes. We know that bone pain is quite common in people with PBC. And actually, I remember, Collette, that work you did last year, the year before, where you collected the word clouds. You remember the word clouds?
Yes.
Pain really came out very strongly in that, didn't it? And it's not something that you look at the medical textbooks. We don't talk about pain in PBC very much, but actually pain really came out in there quite a lot, didn't it? And I think, why might you get pain in your bones and your joints? Well, we know PBC can affect your absorption of calcium, and so people can develop thin bones, what we call osteoporosis, and that can lead to microfractures. Not a break that you can see on an X-ray, but if you look at the bones under a microscope, there are these tiny little fractures in them, and that can accumulate and cause quite significant pain in some people. Of course, PBC is an autoimmune disorder, and it can coexist with other autoimmune disorders. So there's something called Sjögren's syndrome, which some people on this call will have recognized or may even be suffering from, which is a condition that affects the joints and can cause really quite discomforting pain and limitation and restrictions. But it's a condition that can be treated. The other condition that can coexist, and certainly particularly what made me think of this is because of that skin sensitive you talked about, is fibromyalgia as well, can coexist with PBC. And certainly I think if you're having significant bony pain, you're going to need to get that assessed. And generally a rheumatologist is the best person to make that assessment, because particularly if there's inflammatory conditions, which are autoimmune conditions related to PBC, then those can have some very effective treatments. But what you first need is an assessment. If we can get your pain under control, the world will feel a different place, because when you're in pain, you don't sleep. When you don't sleep, you feel more fatigued. And when you're more fatigued, the pain becomes even more unbearable. So it does become a vicious circle. So you need an assessment really to try and break that vicious circle and to try and get you back onto an even keel.
Yeah, 100%. So please come back to us. And even if you don't feel like talking to me or to anybody in the team, come back and let us know how you are. If you've managed to get assessed, let us know, because we do think about people. We do care. I think you've grasped that by now. But all the best to you. So we have somebody with a horrendous itch in the process of being assessed for transplant. Okay. I've been told that I have a significant loss of small bowel ducts. Is this likely to be causing the itch? Well, of course, that's what we were talking about 5 minutes ago, the mystery behind the itch.
Yeah, yes, it can. I mean, certainly if the biopsy and the small bowel ducts have effectively vanished, then certainly, yeah. I mean, if you've got jaundice as well, then the itch can be extremely severe. But as Collette has said, we've all seen people when working with PBC who've needed a transplant for itching, and when they've taken the liver out, the liver is actually fairly normal looking. So it's not just about the amount of damage there. But clearly, if you've got bad itching, it's an appropriate thing to consider an intervention, and it is very effective for that indication as well. So, best of luck to you, because I think that that level of itching is extremely miserable.
Yeah, horrendous. And just a wee tip, and I don't know, the nurses in the Royal Infirmary in Edinburgh gave me this wee tip years and years and years ago to pass on to people, is buying it's Epsom salts. You can get a big tub in the chemist. And if you can have a bath in the Epsom salts last thing at night, or if you don't have a bath, soak your hands, your head, or whatever, rinse it all down. And apparently it's really, really helpful. So just a wee tip for you. Next question. Do you know the link between PBC and gastro problems such as GAVE? GAVE?
Yeah.
What does that? What's GAVE?
That's a great. So GAVE stands for gastric antral vascular ectasia. Okay,
Oh,
so
wow.
that's a mouthful for you, isn't it?
Yeah.
So what happens in GAVE is that the stomach, the lower stomach, down towards the exit point, looks like a watermelon. So you have these big red streaks, and the blood vessels get very close to the surface, and they look very red and angry. And in some people, that can be a cause of anemia, because it can cause chronic bleeding, not like a big gush of blood, but just, you know, cell by cell, you know, drop by drop. So it, you know, it can be problematic and make you feel fatigued if your blood count's running low. Most people with PBC won't have GAVE. It's more likely to occur if you have cirrhosis of the liver, but I've seen GAVE in people who don't have cirrhosis of the liver. And there's probably hormonal things that will change, that will drive some of that in the people who don't have cirrhosis. So it's not a cancerous or precancerous thing, but it can be troublesome in terms of causing anemia, and in some people it needs endoscopies and treatment to try and stop the anemia from recurring. So yes, it can occur in association with your PBC through damage to the liver, but I have seen it occur in people without damage as well.
Okay, I've never heard of it before. Great question. Okay, so I've been diagnosed with PBC and also have been told I have gallstones sludge. On a call with the surgeon, gallbladder removal last week, he said he didn't want to operate on me due to increased risk of bleeding during the operation due to PBC. I don't think PBC would impact on me having this operation. I've been told by my gastroenterologist that they have identified PBC as very early. So do you think that PBC should stop me having this operation and increase my risk of bleeding?
Right, another great question. So I think that is dependent really on whether you have cirrhosis. If you don't have cirrhosis, and if what you're saying there that your PBC is early, you don't have cirrhosis, then that may be a misinterpretation by the surgeon. Is that a good way of putting it? Of, you know, and again, a surgeon might still understand PBC as meaning primary biliary cirrhosis, not primary biliary cholangitis. So he may be stuck with the historical definition and assuming that you have more severe liver disease than you do. If you don't have cirrhosis, there's no suggestion that your bleeding risk should be dangerous. And actually, even if you have cirrhosis, your bleeding risk may still be more than acceptable for surgery. So I would probably suggest you go back to your PBC consultant and ask if they could, you know, give the surgeon their considered view on what your risk is from a bleeding point of view, because I suspect your gastroenterologist will be in a better place. The fact that they've said that you're early stage PBC suggests that they very much know what they're doing and they understand your condition, and so should be able to perhaps put a good word in for you with the surgeon to have your gallstones treated.
Yeah, great question. But there are these wee things sometimes, and it's not uncommon to have gallbladder stones in the gallbladder or gallbladder disease with PBC. It's in the old days it used to be the 3S, fair, fat, and 40, but it seems to be quite more common in PBC people. Okay, I'm newly diagnosed with PBC a few weeks ago, and I've been seeing in groups that a lot of people have bone density scans after diagnosis. I've not been told anything about this, and one of my symptoms is severe bone pain. Should I push for the scan to be done?
Yeah, good question. I think, yes, I think if you've got bone pain, yes, you should. I think when you look at what the old guidelines have said about bone density scans, the data is quite old, and the group that are at risk are females who are postmenopausal, and if you have advanced liver disease, absolutely yes. Otherwise, if you're not cirrhotic or you haven't got any symptoms, then the probability of you having thin bones is a lot lower. But certainly, with what you've just said, I think a bone scan would be important as a baseline assessment. So I would push for it, yes.
Yeah, and then I think we get them maybe 5 or 6 years. I can't remember, and there's nothing to them. You just big questionnaire, by the way, about your eating habits and everything else, which is good. And they'll give you advice on if you're not taking enough calcium or if you are, which is good. Right, last question. What does a bright liver mean?
Yeah, okay. So this is something that you get on an ultrasound report, okay? And so when they're looking at the liver, they look at the liver and they also look at the kidneys. So the kidneys are normally brighter than the liver on ultrasound scan. But if the liver looks as bright as the kidneys, that usually means that there's fat within the liver. Okay, so if a bright liver usually means a fatty liver. Now that's extraordinarily common. Probably 30-35% of the adult population will have a bright liver on ultrasound. But certainly, coming back to what I was saying about alcohol earlier, if you've got a fatty liver and PBC, that could be an additional factor that might lead to more damage over time. So it's one of the things that would be important to address with modest weight reduction. We advise around 7 to 10% of your current body weight reduction to improve the amount of fat within the liver if it looks bright on a scan, just to try and keep your liver healthy in the future. And also there'll be secondary benefits as well in terms of reduced risk of diabetes in the future, high blood pressure, and conditions like that. So a bright looking liver we would regard as being a fatty liver, and that would be important to just make some simple lifestyle changes. Think about movement as medicine, getting fit and active, thinking about your diet. You see, I listen, Collette, I listen. And so think about those things just to look after your liver and your general health, you know.
I have two of these. This is my movement as medicine. But the one thing, you know, what you're saying, one of the beauties about that is at least you can do something about it. PBC, you can't, you're stuck with it. But yeah. Well, everybody, that's been a great session. Andrew, I can't thank you enough.
No, sorry for the late start.
I apologise. We've had techie issues and everything else. I'm going back to my holiday finishes on Saturday. I'm here having a lovely time in Northumberland. We're having cracking weather here. I don't know what you people are, but we've been out every day.
It's
Alan,
thank you.
Thank you, everybody. Alan, I'm just going to say thank you. I'm going to let everybody go because it's I'm starving now. Something fantastic as always, main thanks. You're more than welcome.
Absolutely fantastic.
Thank you, Alan, and thank you, Chris, who's in the background as well.
Can I just say, Collette, just to remind people, we don't have a webinar next week because we don't have the services of a guest medic. So the next one's the 25th of November with Dr. Vino Tagadi.
And the 25th of November is Robert's 50th birthday.
When 25th? I shall send some abuse, yes.
Yeah, absolutely, 100%. Okay, everybody, thanks
everybody.
All the best to you. Okay. Bye, everybody.
Just now.
Bye.
Bye.
Sorry about that, Alan.
Thanks very much.
Yeah, sorry about the issues earlier.
Yeah, take care. Thank you.
All the best now. Ta-ra.